I'd now like to invite our second speaker to the podium, and our second speaker is Miss Elizabeth Healy. Elizabeth is an Assistant Director of Public Health Nursing, and she works in the services, the South Lee services. So thank you, Elizabeth.
So thank you to everyone for inviting me to speak here today to speak about the quality metrics in the public health nursing service. And it's a real privilege for me to be here, similar to the previous speaker, because I'm very passionate about quality. And quality in public health nursing is a little bit different to the acute sector because we're lone workers. And as I go through this presentation, it'll become a little bit more evident. So just to put our service in perspective, I'm part of the South Lee Public Health Nursing team. I'm an Assistant Director in Sector 2, and in the whole of South Lee we have 47 area PHNs and a total staff of 74 whole-time equivalent posts. That includes all grades from management to area PHNs and school health service. For anyone who is not from Cork, the River Lee divides the city. So we have North Lee and South Lee, and we're the south side. So to talk about quality care metrics from the beginning, where we got involved and where our passion came from, and our interest in quality care metrics. And I suppose for myself, why I embraced this in the beginning is, I suppose the community is a much smaller team, and we have different challenges than the acute service. And I think realistically, no matter who has an audit, whether it's in the acute or the community, there is always a bit of anxiety about audits, both for the staff who are going to receive their results of the audit, but also for the managers, because we're always in a little bit of tension. Are we reaching target? And are we providing the best service and the best evidence? And when I heard about the quality care metrics, what I heard about it is that it is a form of an audit. It's an audit tool, but it's different because it's for the staff. It's for the staff to improve their practice. It's carried out by the staff with management, with all grades. And it's to improve services so that when we do actually go on to have our formal audits, we don't have anything to fear because we're actually reaching target all of the time. So that very much appealed to me. So then to start with where we began and how we approached the metrics. So as a team in the South Lee area, which is obviously part of CHO4 Cork Healy, Community Healthcare, what we did is all the staff attended an information session in the NMPDU. So they went to the information session, and this was really important for us to get going because it couldn't be a top-down approach. It had to be bottom-up because it had to be the nurses who were seeing the patients. So all staff attended the information sessions in MPDU, from the RGNs, PHNs, ADPHNs and directors. And, that set us off as, we had a universal platform. There was no distinction of grades because we all look after patients, and patient care outcomes is really all that matters to us. So all staff attended. They were all issued with their username and password. So immediately once they got their username and password, they had ownership of the project and they were involved. So then where we led from that is we needed a representative on the national work stream. And the representative in the national work stream is a community RGN, Martina O'Shea. And this again highlights the importance of a bottom-up approach, that it wasn't, because we can have this idea in the community maybe that public health nurses are more qualified or that we're the caseload managers, but we all have equal importance when it comes to patient care. We all have a duty of care to the patient. So from there then we had the 4 quality care metrics that we were measuring, which were issued for the community. So we have nursing assessment, nursing care planning, discharge planning, caseload management, which is hugely important when we tie in with our KPI metrics, and also achieving the NMBI regulations and standards. So how we set about it is we were given a target of 10 client files to be audited per sector per month. And in the CHO4 Cork Healy Community Healthcare, we're still at sector level. We haven't got onto the networks yet. We're a little bit behind. But the sectors really equate to a network. It's just that we still call ourselves sectors. So at sector level, which is a network level, we involved all frontline staff, as I said already. The reports were inputted and they were printed off in various different ways with different health centres and primary care centres, because in the community we still have our old-fashioned health centres and we have these fabulous new primary care centres. So it depended on what was available. So they went up on shared folders, they were brought to team meetings, and in some cases it was hard copies were distributed and disseminated to staff. The results at local level were discussed at team meetings, so you have your PHNs, RGNs, RMs, with their director or assistant directors, and we discussed the findings, where our deficits are, where our challenges were, and also very important to give affirmation for good practice. Following on from that, the assistant directors would meet with their director and discuss the outcomes and see where achievement was achieved, where we achieved, and where our poor performance or non-compliance were identified. And we had plenty. So I suppose what was really good about this, it was a no-blame game. It was really to get a baseline and, improve practice. It wasn't about saying we're not performing well. We performed as low as 20-something% and as high as the 90s. And it was really about improvement. It was completely anonymous and it was by the staff, so it was all about improvement. So there was no threat. I think that's really significant. So in our the contribution of quality care metrics to the improvement of nursing practice was really centred around identifying the gaps and addressing that. So when we looked at our metrics, we could see very generic trends. So we analysed the trends, and I suppose for people who are not working in the community, it might be a little bit difficult to understand, but in the community, a public health nurse works on her own. She's a complete lone worker, and she has her caseload and her files. And it's quite possible that no other nurse would be making entry into that file, especially if a nurse works full-time. If they're job sharing, there are 2 nurses. When you're on holidays, possibly. But the fact that you work on your own and you're a lone worker with your own files can lend to deficits, because there's really no one to pull you up. If you're working with colleagues, you learn from each other. But I suppose this is why it's important for us. So some of the generic things that we identified immediately from the metrics was the client's name, address and date of birth on all pages of the file. And this might sound like something very simple, but actually when you're in the community, it's a patient file. There is no one else entering into that file. And obviously their name, date of birth and address was on the front of the file, but in subsequent pages, it might just be their name. And that wasn't best practice, particularly around assessment tools and socio-demographic sections of the file. You would have their name and their date of birth possibly, but not all the required data to meet the regulations. Also the nurse's name and signature on all pages. Again, it might possibly be a signature, but on every single page of the file. And this is really significant because a page can fall out, Also, their name and signature on all entries. We had a practice where we just signed, but our name wasn't necessarily on it. The use of the 24-hour clock, allergies not being documented. And of course, we can't provide any care without knowing if the patient has allergies. The infection status wasn't on the file. A lot of these items actually was attributed to the file we had that needed to be updated. And then focused interventions, because if we didn't establish on admission of a client or a patient onto our caseload, if they had a history of infection or what that was, we couldn't focus our interventions, so we weren't providing best care. Care planning was seen as a big deficit because we're notorious scripters. We're great for writing, but we're not very good at actual care planning. We provide very good care, but we didn't have the evidence. And that was identified as a deficit. Also, discharge planning. We had, I suppose, historically habits, because we see a lot of elderly clients, especially frail elderly clients. And we had gotten into this habit of, we had active files and discharged files, and we had this other group of inactive files. And these were clients that we kind of tended to hold on to because they were frail elderly, they had no nursing care need, no care plan, but we kind of half thought they'd turn up again, so we'd hang on to the file. But this didn't lead to focused interventions. And it had, not alone was it not best practice, but also space is premium, and cabinet space is premium, and floor space is premium. So this was fantastic intervention. So to focus on active discharge planning, and also to focus the mind of the nurse, that focus on the patient, identifying needs, and active discharge planning where appropriate. Also the HSE Code of Practice for Healthcare Record Management and the use of abbreviations, which the former speaker mentioned, that we can use slang and not abbreviations that are standard or meet the regulations of NMBI or the HSE. Also, nursing record or file, well, we identified that needed to be revised because it didn't lead to to best practice, and it was lowering our percentages when we were doing the metrics. The motivation of staff to address the deficits. This was really important because when we started off in the metrics, we were performing very poorly, and it was important that the nurses didn't become demoralised and want to give up. So the participation of staff was very important in implementing any change, and also to promote CPD because they needed education and to get the whole CPD interest. I suppose just to mention as well, when we were doing the metrics, I suppose to speak for myself, all grades did the metrics and we did it in twos, because to do it on your own can be a bit laborious and time consuming and daunting. So 2 staff always do the metrics, and in any grade it would be 2 RGNs, 2 PHNs, RGN, PHN, ADPHN, RGN. It didn't matter what combination, but that everyone was doing the metrics and everyone got exposed. And this was really useful because the deficits were very generic. So when people were auditing colleagues' files, they're totally anonymised, they would identify their own deficits as well, So it was a learning, and it really engendered interest in developing it, and also CPD. So then when we had established this and we knew what our deficits were, starting to know what our deficits were, we had to do something about it. So we were looking at the different models and tools of how we could make a change. So the model we adopted was the PDSA model, or the PDSA tool. And this is a quality service improvement tool. It's very simple, very easy to follow, and very user-friendly. So in this tool, what it really looks at is the plan, do, study and act. It's very concrete, and there's a great template in the document. So what we did then is we have to look at what have we got to accomplish, what are we trying to accomplish? How do we know that the changes we make will actually lead to improvement? And what change can we make that will actually result in an improvement? So from there we went to our action plans. So action plans had to be drawn up to make the change. So while I speak for myself, this was done at every level, like I say, from bottom up. And, the assistant directors feeding into the directors, and the 5 directors of CHO4 meeting collaboratively together to make the change happen. So in the PDSA model, sorry, there's a typo in the models, it was a model, this tool is what we used. So we used it to implement the change following the collection of metrics. So from the planning perspective, we analysed the reports and identified the deficits. In the doing, implementing an improvement which led to an increase in patient safety, quality improvement, accountability of staff, and increase in staff morale professionally. And like I said already, it was really important to keep the morale up. And because the girls were so involved in it themselves, the morale was up, So from a study perspective then, to study the measurement is really a critical part of the testing and implementing changes, because you need the data to implement the change, and it informed the team as to whether the changes we were making actually was leading to an improvement, and I'll elaborate on that a little bit more. And also gave an opportunity to nurses to critically review their practice. That actually was one of the most inspiring thing for the public health nurses, is to identify their own deficits and critically review their practice, and particularly their documentation, creating a safer environment for the nurses themselves as well as the service users, because we're very patient focused and service users, and it's almost a buzzword, but also to protect our own licence and for us to be the best nurses we can be. And then going on to the action again, going back into the cycle of change. So the outcomes of the quality care metrics, the directors of public health nurses met collaboratively and coherently, and they could see that what was being identified through the quality care metrics was similar right across CHO4. That, there was really great similarities and the needs were similar. So this led, first of all, to a huge rollout of educational programmes, because education was seen as key to change. So to run through the major training programmes that we had was supported by the NMPDU, was preparing for HICWA inspections within the public health, community health settings. And this was very important because HICWA has not come out into the community yet. And when we don't have it, we're afraid of it. So I suppose to do this course really was very enlightening, and it took the fear factor out of it. So this was a one-day programme, 5 educational points, and 2 of these programmes were rolled out in August 17, and 59 public health nursing representatives attended. Documentation was seen as a key area, and arising out of this, from the directors going to the NMPDU collaboratively, an educational programme was rolled out for public health nursing entitled Accountability and Responsibility in Documentation to Support Safer, Better Healthcare for Public Health Nurses and Community Registered Nurses. And this was a bespoke programme rolled out by the NMPDU, and I have to say it was undoubtedly one of the most successful sought-after programmes that I have ever participated in. All nurses wanted to be involved in it. They all wanted to participate in it. It was constantly oversubscribed. We were all ready to fire off our emails and it would bounce back saying it was full. So this really was very innovative and a huge investment from the HSE. And this spanned from September 17 to April 18. And it went through Storm Ophelia and Storm Emma and status red alerts, but nothing stopped this programme. The show went on, and imagine like the amount, 379 staff were trained. So this was a huge HSE investment. We also had 2 other programmes, self-neglect, because this was identified as a need from staff, particularly around the areas of consent and capacity, advanced care directives, assisted decision making, safeguarding, and this was identified as a need. So this a masterclass was put on. Also that day was another masterclass, which was a quality initiative on indwelling catheter care management. This was a quality initiative because this guideline spans staff, patient, home helps and the acute care, because there's a passport for patients. So this was a very large document that was rolled out. And also, subsequent to that, nurses have a huge concern in the community about Alzheimer's dementia and their responsibility to that. And we were very fortunate that the tool we're using is the Dementia Wandering tool, and Professor Dewing was in Cork and Dean in PDU tipped me off, and I got onto the CNME in the Mercy, and Anne Cummins came in storming and she coordinated and facilitated in jig time, and we got our staff there and 50 people got to attend. We didn't have NMBI credits for that because the time frame was too short to apply for credits, but everyone got a certificate of attendance for their portfolios. So just quickly, because I'm running out of time, the improvements in nursing was education was a huge part of it. Information for patients, our clients was increased, practices were improved, greater awareness for professionals, good staff engagement, empowerment and ownership, definitely a sense of pride, improved technology. We went from 1 PC between 4 people to all having laptops and tablets, which was a great boost of morale as well. Trends were identified, and I suppose the nursing records were revised, and this was a significant piece of work because we found from the quality care metrics that our documentation didn't lend to better practice. So we had focus groups, and the public health nurses gave feedback to meet the regulations, so we had new tools added, and the documentation was revised to ensure best practice. So for the future, I suppose the big challenge for us now is to link quality care metrics with primary care metrics, because the quality care metrics need to knit in with our primary care metrics to demonstrate both the activity and the quality of service. We need to retain ownership, because for accountability and responsibility and best care. Also, resource and time is always going to be a challenge for us, particularly when I go to the last point, because we have 14 new metrics coming down the track which are just published, with 69 indicators, and that can lead to a fear factor. But I know when we started off, it was take us 4 hours to do 10 charts, and now we can do it in an hour and a half. So you get faster, and definitely 2 people together, are more effective. And to test your care, it really is very user friendly. There's nothing to be afraid about it. So I would say keep calm. It's not rocket science. Think quality, because we have no choice but to think of quality, and together we can do it better. So I'd just like to thank the National Office, to thank Carmel Buckley for her support, who is always there for us. It doesn't matter what her grade is, she always picks up the phone, she's always available to us, and a huge support. Also to thank the officers, Aoife Lane, who former NMPD officer who started this process with us, to Joan Downey, Sinead Kinnear, and Fiona even, Wills, who have been hugely successful in implementing it, and a huge support to me and a huge support to the staff. And also to thank the CNME and the Mercy, who have been hugely supportive to us. So thank you very much.